I'm Bruno Paiva from the University of Navarra in Pamplona, Spain. At EHA 2025, we are presenting an oral abstract about MRD Kinetics, both from the prognostic as well as from the biology point of view. From the prognostic point of view, we have generated an issue, in my view, and is the fact that nowadays MRD is being assessed much more frequently than in the past, maybe 3, 4, 5, if not more assessments in a single clinical trial. And whereas in the past it was easy to classify patients either into negative or positive, or resurgence or clearance based on 2 assessments, nowadays no one knows how to classify when you have 5 or 6 different assessments. So we tried to answer this question by collecting data from almost 1,800 patients, almost 4,000 MRD assessments, both in clinical trial and real-world cohorts, and the results were completely validated in the 2 settings, and we were able to segregate patients into 3 different subgroups. One with sustained MRD negativity, all assessments were negative, unprecedented outcomes, PFS and OS of almost 85% at 6 years and beyond, and then a new subgroup of patients with positive yet stable MRD levels for whom the PFS is not as good, but is actually very positive, and the overall survival is as good as those patients with sustained negative MRD, and then a subset of patients with positive and evolving MRD levels that present with significantly inferior PFS and OS. And we show it in multivariate analysis, again in the real world and clinical trial cohorts, that positive evolving MRD levels is the strongest risk factor to predict inferior progression-free survival. From the biology point of view, we show that there is continuous genomic evolution from diagnosis to MRD to relapse. In fact, the MRD clone is almost like a bridge in between diagnosis and relapse, with a lot of genetic alterations and transcriptional adaptation to treatment. And therefore, based on those findings, together with modulation of the bone marrow immune composition that we observed throughout treatment, we hypothesized that early interception of MRD, when compared to immunotherapy at the time of clinical relapse, could drive some clinical benefit. And we leveraged on the mice models developed at our university by my colleague Martinez Clement to show that indeed treatment with an anti-BCMA CAR-T at the time of MRD, as opposed to clinical relapse, does improve survival in mice, and therefore this concept should be investigated, in our opinion, in clinical trials.